Dr. Thiru's talk is pending, so we will just let you complete your talk.
I may take your leave. Thank you so very much, Thiru and Ramesh. It was really a pleasure to be here and to join the conference. Appreciate your invitation, and this is an opportunity also to see, even if it is online, Keelan. You have a wonderful conference, and I wish all our colleagues in India to have a wonderful conference and a good continuation of the rest of the conference.
Thank you,
Have a
Dr.
wonderful day.
Thank you,
Bye-bye.
Dr. Sandhu. We had a wonderful time yesterday and today. We had about 6 endoscopic procedures just to diagnose, and today we did about 5 endoscopic and then one definitive surgery with the web, with the keel and other thing. It went on very well, and we missed you. Maybe next time.
Thank you so much.
Thank you
For
so
sure.
much,
Next time.
Dr. Sandhu.
Bye-bye.
Thank you so much.
Sure, thank
I
you
know
so much
for being
you're
here.
in London, so
Bye, Keelan. You take care.
with
Cheers.
this
Bye, Thiru.
busy schedule,
Bye, Ramesh.
I wanted to-
busy
Bye-bye.
schedule,
I wanted to
you
say-
made some time to spend some time with us. Yeah, Dr. Colin want to say
Pleasure.
something.
Kishore, I wanted to say thank you for your talk, and it's always so enlightening to listen to a slightly different perspective from across the pond. And there are things that are different, but it's enlightening and encouraging to see a lot of similarities to what we're trying to do in the opposite coast in Seattle as well. We don't do quite as proactive with the stenting, I think, in the intubation injury setting, but the concepts with topical antibiotic and steroid ointment are things that we've been increasing our utilization of, and it's been really rewarding to see that, including I actually had a set of twins recently where I was consulted on one and one of my colleagues was consulted on another, identical twins, both the same prematurity, and I used extensive topical Tobradex, a steroid antibiotic on one. It was not used on the twins. So the ICU actually got the case control of these twins to see what happened with their mucosal injury, and it was a dramatic improvement to show what can happen with that topical application. And our ICU is now much more prone to call and say, get me or our colleagues that are more prone to and involve that treatment to be providing that earlier and increasing the mucosal preservation that can occur with that approach, even prior to tracheostomy placement. Because if you just go and place a tracheostomy and don't do anything else, then you're guaranteeing a grade 3 or 4 subglottic stenosis for that patient. So it's really wonderful to hear your talk as always, and we just appreciate your wisdom and are excited to see the knowledge of these concepts kind of spreading from India to Europe to the East Coast to the Midwest to the West Coast in the United States as well. So great to see you. Thanks.
Thank you so much, Keelan. It's really a pleasure to see you and really appreciate 100% everything that you said.
Nice to hear this from Dr. Colin, because 10 years back when I was in CHU, I saw a lot of patients being used with this kind of steroid ointments, and patient recovered very fast. Then I came back here, I started using for the past 10 years we've been using. That's what Dr. Ravi presented today with all these intubation related injuries patients. But this message was not reached that much that time to US. But now I'm happy to hear that you people are also taken up this, because we have started collaborating and they're planning to publish this with the CHU maybe in future, so that more people will take up this and get benefited. Thank you so much. Thanks for your comments. Thank you. Okay, anyway, thank you. So anyway, I'm not going to one second. I'm not going to talk any data. I'm not going to present any data here because everything is presented by Dr. Ravi. This is our data. So we are not intending to make mistake, right? And especially when intubation, our intention is to give some good relief to the patient when the patient is struggling, and we are able to save a lot of patients. And with the modern state of the art NICU and PICU setup nowadays, we are saving a lot of patients with the good intention, but still there are some mistakes happening, and how we can improve on that is the prime idea of this talk. So these are all experiences. So this child, a newborn, in the middle of the night we were called. Myself and Dr. Ramesh came. There is a newborn child with stridor post intubation. They were not able to intubate. So middle of the night we came and we saw there is something like this. So then immediately we did, that time we couldn't find any balloon. So we used the bougie to dilate that immediately. You can see how the airway improved, and we reintubated with Sofradex ointment and kept the child intubated for 48 hours and extubated. Now you see how the airway looks. Just dilatation at the right time and a little bit of ointment. So see this is the most common problem. There is a mucosal laceration. What happens to this laceration, especially when the mucosa is sitting over the cartilage? There is nothing in between. There is a mucosa and then cartilage. If you injure that, there will be a perichondritis. So if you leave this, the inflammation will be continuing and you will have some amount of problem, either granuloma, and that will mature into the scarring. One good thing is here, there is no posterior glottic mucosal injury. So that means there will not be any circumferential scarring, so that stenosis will happen. See here, this is a typical intubation granuloma where the endotracheal tube will be sitting posteriorly, where the arytenoid cartilage vocal process will be in contact with the intubation tube. So if you are putting little oversized tube, what will happen? There will be a mucosal laceration and perichondritis that will become a granuloma, reparative granuloma. So if you don't remove that, then there will be a problem. So this is how we inject ointment. So this is again infant, like 45 days old baby. Here this is the intermittent stage. There is thin mucosal subglottic stenosis. So straight away I went in and ballooned it without doing anything, without cutting or doing anything. I just ballooned it, and the airway looked better after that. And this kind of thin injury already matured, all the mucosa around is healthy. So that means if you just balloon, then even one ballooning will be enough. You can see the airway then. So this is not a very infrequent finding when we go inside and see. There will be some fibrin deposits, and you just go there, remove that fibrin deposits. If you want, you can reintubate and apply some ointment if there is some raw area. If there is no mucosal injury, you don't have to do the reintubation or ointment application. We tell the ICU persons that the child will be coming back without the tube, because there is no mucosal laceration. There is no point in reintubating in those kind of patients. So most of the patients will be having just edema. In that situation, the IV steroids works. In case if there is mucosal laceration, it's better to apply local steroids than IV steroid, because when there is a laceration, the local application will be effective. So this is again, this is a typical scenario. The post intubation, patient will be all right with the primary problem. The child will go home. After 1 week, the child develops some other problem, something like this. Child will be coming with the stridor. So when you go inside, I saw there is a band connecting it. So immediately I used just a cold steel cutting knife, cut it and dilated it, and immediately the child improved. So this is how the circumferential stenosis will look like. If you leave it like this, then there will be a circumferential scarring and finally stenosis. So at this point in time, if you dilate either with bougie or balloon, then that area will be all right. But if you balloon it and there is a raw area, circumferential raw area again, if you leave it like that, then there is a chance of rescarring. So in that situation, you put one size smaller tube, apply ointment, and come out and do the frequent scopy, see how the healing is happening, whether the child is improving. In case if needed, you can go for multiple dilatations, so that the interval of dilatation also come down over the period of time. Earlier we used to do once in a month dilatation, and then it came like 3 weeks, 2 weeks. Now even people are talking about within a week. Have a look within a week. When it starts again, you do dilatation, then this will improve. So this is how we do the apneic anesthesia technique. When we put the bougie will be there inside. When the saturation goes down, maybe around 70 or something, then we just remove it and then put a endotracheal tube through the suspension microlaryngoscope and ventilate nicely. Keep the saturation to 100 and then remove it. Do the procedure whatever you want, and then apply ointment. There. Sometimes we will just plug the ointment in the airway, without tube or anything. That will seep down and line the all around the raw area. Then that will heal off. So cuffed or uncuffed tube, there was a question in the panel. See what happens with cuffed tube. So once we got a call from some other hospital. Patient was referred for, they are not able to remove the endotracheal tube. So endotracheal tube is stuck inside. They were not able to remove it. So patient was shifted on with the tube on a ventilator. So then I went and saw the cuff was inflated. We are not able to deflate the cuff. Then I used the endoscopy control, used the needle to go and puncture the cuff, and then we were able to remove it. What happened after that? We saw, because of this over extension of the balloon, the posterior membranous trachea was torn apart. So it was like a lengthy tear right from the cricoid lamina till almost like lower end of the trachea. So there was a huge rent. So then first time we are also seeing this kind of a problem. Then we discussed with all my friends abroad. So everyone suggested to do a lower down endotracheal tube. Maybe you can put a cuff little bit below and start ventilating the patient for maybe a week or so, and then extubate. Then it will be all right. So it happened like that. This is after 7 days of ventilation. So you can see that rent is nicely healing with the granulation. So we were lucky enough to come out of it without doing any cervical approach to close that long rent.
And there was no esophageal injury in that, correct?
Yeah. Luckily there was no esophageal injury. So that's that's why we escaped.
Yeah.
So, yeah. So this child again, post intubation, acute injury. There is some mucosal laceration in the mucinous deposit, edema. It was like it was not exactly like one particular point mucosal laceration or stenosis or anything. So then as usual, we reintubated with ointment and ventilated for 2 more days. After that we removed. There is a fairly good healing happening, and not much of raw area, not much of stenosis. Then we thought we are getting away with the airway problems. So we sent the patient home. After 5 days, patient came back again with the stridor, and I scoped it. There was circumferential stenosis, thin subglottic stenosis. It started, but this time I ballooned it. and I was able to get a good, nice dilation, and airway was good, not much of mucosal laceration. Then we sent the patient back home. For our surprise, patient came back again after a few days, but this time everyone was ready to do a tracheostomy, because intensivists were like little skeptical about keeping the child again, and parents were like, how many times you'll be telling that everything is all right, you can go home, and after sometimes we are coming back again and again, so you will have to do tracheostomy. So that's how the argument was, but the parents were not ready for tracheostomy. So that is the good thing. Sometimes when we offer something, they say no, that will turn out to be good for the patient. So then after this time, I took the patient for tracheostomy. I thought I will have another look before doing tracheostomy. I did a scopy. Now there is only glottic and subglottic, little bit of on the undersurface of the glottic edema. Subglottic looks absolutely normal. Every single time when you do scopy, the findings are different in this case. But this time it's only edema. So then we thought it is only edema. We will, give IV steroids for some time, and then we'll see. So luckily, without doing tracheostomy, the child went home without any problem after 2 days of IV steroids. This is the final one. So that's all from my side. Any comments from Dr. Colin?
I'm just grateful that you're there providing the services you are for those children. It's I think the concepts you describe are really accurate with what occurs with the pathophysiology for those patients. I think when we tend to use balloons more than bougies, so it's enlightening for us to see that you can have good outcomes as well if you use the right concepts with that different tool with the bougie instead of the balloon.
We used to do a lot of bougies earlier. Then we started doing balloons, and we also have a comparative study which was presented in Cincinnati Quad Conference by Dr. Laya. So we have a comparative study of bougies and balloons. So incidentally, there is not much of difference, though our sample size is not robust. There is not much of difference as such, but we somehow started doing more of balloons, because now we are more comfortable using balloons.
Yeah, and the balloon is nice to kind of be able to carefully get it through a smaller stenosis with endoscopic guidance, and then below the balloon up, where with the bougie that's a little bit more blind. I think the only other thing I noticed you used the needle for the cuff, but I'm curious how often you use a needle to inject steroids as well, because that is another really important piece of our algorithm, is that anytime there's granulation tissue, especially like a pedunculated piece of granulation tissue, occasionally we will actually excise that or remove that, but injecting it with Kenalog can be just as effective and sometimes less traumatic. So especially if it's on the vocal folds, I'll often inject Kenalog into that rather than excising it.
Yeah, we do inject Kenalogs, but injecting Kenalogs mostly when there is little more scar formation, or the granulation is like sessile, when we are not able to remove. At that time we use Kenalogs, and also we use Kenalogs before dilating any matured subglottic stenosis, but not routinely we use Kenalogs. When there is a pedunculated polyp or granuloma kind of a thing, then we just remove it without injecting.
Yeah, that was traditionally our approach as well, but I've started using Kenalog more, especially if it's on the vocal folds. And it's kind of amazing to me how many of those things will just melt and you don't ever have to excise them and remove any of the mucosa. And we do use the Kenalog basically for every stenosis before we do balloon dilations as well.
So regarding the case where you have mentioned there was a posterior tracheal wall injury, if that patient had a tracheoesophageal fistula because of the intubation injury, what would be your next step? Would you go and repair the fistula immediately, or would you intubate, bypass the fistula, wait for some time?
Yeah, that's a great question. Like, when there is acquired tracheoesophageal fistula, we had a case of acquired tracheoesophageal fistula, something like this, because of button battery injury. There was a very long rent. Okay, then we didn't know what to do. So that time the child was tracheostomized because of stridor, and child also had cricoarytenoid joint fixation because of the button battery, and as well as tracheoesophageal long rent. Okay, so we done this, and peg was done for that baby, and then I discussed this with Dr. Reza Rabar from Boston when I met in one of the conferences. He said, you don't do anything, just wait for some time, maybe for 4 months or 5 months. So I said, okay, I can wait for the tracheoesophageal fistula. What will happen to the cricoarytenoid joint fixation? Because there may be evolving inflammation there, and is there a possibility of cricoarytenoid joint fixation? Then he said, you wait for both. Both areas need not be aggressive, because whatever you do when there is inflammation happening, and especially when there is chemical reaction happening in the mucosa, if you try to correct it, you will end up with a failure. So just wait and see. So that's what we did. We waited for 6 months. For our surprise, both this cricoarytenoid joint movement improved, and this rent also healed off. Then we were able to remove it. So in case if you want to do some suturing or something, it's better to wait at least for 6 months when the inflammation and chemical reaction goes off. Then maybe it is possible to do it. But in this particular case, it is only a tear. It's something like a clean cut. Here, maybe you can straight away go and suture it.
Because we had a patient, not a pediatric but an adult patient, intubation injury was there, and she was referred to us that she was not able to get ventilated. She had a posterior tracheal wall injury with a tracheal fistula. So we did a tracheostomy, we bypassed the fistula site and we put the tracheostomy inside. But because of the tracheostomy balloon pressure, the fistula kept expanding. So then we put a longer tracheostomy tube, then we bypassed the fistula. And because the balloon, it kept on increasing and increasing. And she was GBS patient, so she needed to be on ventilator. And finally the tear went on till the carina, and we could not ventilate, and she succumbed to that expanding fistula site.
Your thoughts, Dr. Kalan?
Thiru, how long did that fistula take to heal when you watched for 6 months? Do you remember when it actually healed?
Yeah. Come again?
Do you remember when that fistula healed when you watched for 6 months?
See, the last endoscopy we did was 3 months earlier. So the next endoscopy was 6 months. So maybe within that 3 months to 6 months. So we were not able to, they lost follow-up also. They came only after 6 months. So it would have happened between 3 months to 6 months.
Yeah, I think that's a really important point to remember with button battery injuries, is that the injury will continue to evolve and it will get worse before it gets better. So we found the most recent one we saw, we did the button battery removal and there was no fistula and everything looked totally healthy in the airway. And we said, don't trust it. Don't get your hopes up. The fistula showed up like a week later, and we sat and watched, and it was about 2 months before that fistula actually closed on its own, and it was a small fistula. But we've also had those cases where a patient had a button barrier that was in place for 8 days, and then it was removed with a large 3 centimeter fistula in an 8-year-old. And they came to us intubated with the cuff sitting right on the fistula. And so we actually we tried to move the cuff lower. We couldn't do that. We were worried about the same thing you described with the fistula expanding just based on the cuff pressure. So we actually fitted the patient with what's called a cuirass, which is like an iron lung. It's a modern iron lung where they had a chest, a plastic cavity around their chest that would expand to increase their ventilation to move their chest wall out. And that was what generated their ventilatory pressure. So that was a method for that patient to actually be able to extubate them and support their ventilatory needs without intubation. And that was something that allowed the fistula to stabilize. They were on that for 2 or 3 weeks. And then we were able to take them for their slide tracheoplasty once we confirmed that the fistula was no longer expanding. And it was about 3 centimeters, so we did a slide tracheoplasty for that repair, utilizing some of the tracheal cartilage as a layer of the closure, and the patient did well with that. But I mean, those are very important lessons to learn, is how long it takes for things to heal when there's a chemical injury involved.
Thank you so much. That's very interesting.
I have a small doubt. Whether, like, from intensive perspective,
Mike.
from the intensive perspective, difficult to ventilate as you mentioned with this rent. Like whether double lumen ET tubes where you do ventilation separately, where you bypass and do, whether those things can be done or considered. Double lumen ET tubes.
Yeah, I think that can absolutely be considered. I think it all depends on where the fistula is. So the first patient I mentioned, the fistula was in the trachea, so that would be more realistic. One of the other patients, the fistula was right at the carina. So it becomes difficult to find any tube that's going to, kind of adequately bypass everything and keep that patient safe.